Anatomy of the shoulder joint. The bones that make up the shoulder joint include the clavicle, scapula, and humerus. The bony structures of the scapula are easily palpated. The acromion process is located on the lateral part of the shoulder right above the shoulder joint. The coracoid process can be palpated under the lateral part of the clavicle, about 1 inch below the anterior edge of the clavicle. The glenoid fossa is a concave structure in which the head of the humerus articulates. This is what we typically refer to as the shoulder joint. The spine of the scapula is about 3 inches. The spine of the scapula is about 3 inches long. It's a thin projection which runs medial to lateral and is at the same level as the spinous process for thoracic vertebrae 3. The spine of the scapula can be palpated across the upper part of the posterior surface of the scapula. The medial, or vertebral border, is the edge of the scapula closest to the vertebral column. This sits about 2 inches from the spinous processes. The medial border runs in a superior to inferior direction. It is easily palpated and may even stick out if you place your arm behind your back. The lateral or axillary border is on the outer edge or lateral surface of the scapula, located between the inferior angle and the shoulder joint. The superior angle is located above the vertebral border or medial aspect of the scapula. It is at the same level as the spinous process for the thoracic vertebrae 2. And finally, the inferior angle is located between the vertebral and axillary borders. It is also known as the point at the bottom of the scapula and is at the same level as the spinous process for thoracic vertebrae 7. There are 4 joints that make up the shoulder joint. The shoulder joint itself is known as the glenohumeral joint. It is a ball and socket articulation between the head of the humerus and the glenoid cavity of the scapula. It is important to note that the ball, or the head of the humerus, fits into a very shallow socket in the scapula called the glenoid. One can see that this ball does not fully fit into the glenoid cup. This allows for a wide range of movement provided by the shoulder, but it comes at a cost for skeletal stability. Joint stability is provided instead by the rotator cuff muscles and related bony processes and glenohumeral ligaments. The other 3 joints of the shoulder are the Acromiooclavicular Joint, or AC joint, which is where the clavicle meets the acromion of the scapula, the Sternoclavicular, or SC joint, where the clavicle meets the chest bone, or the sternum, and the Scapulothoracic Joint, where the scapula meets the ribs at the back of the chest. The shoulder joint is a multi-axial synovial ball and socket joint and involves the articulation between the glenoid cavity of the shoulder. The shoulder joint is a multi-axial synovial ball and socket joint and involves the articulation between the glenoid cavity of the scapula and the head of the humerus. Due to the very loose joint capsule that gives a limited interface of the humerus. The shoulder is the most mobile joint in the body. This is due to the very loose joint capsule that gives a limited interface of the humerus and the scapula. The shoulder joint The socket of the glenohumeral cavity of the scapula itself is quite shallow, but is made deeper by the addition of the glenoid labrum. The glenoid labrum is a ring of cartilaginous fiber attached to the circumference of the cavity. This ring is continuous with the tendon of the biceps brachii. We can see the difference between the hip and the shoulder joint. The hip is much more stable than the shoulder. The shoulder allows for more range of motion than does the hip, so we sacrifice that stability for flexibility. Flexion and extension of the shoulder joint occur in the sagittal plane. Flexion is carried out by the anterior fibers of the deltoid, pectoralis major, and the coracobrachialis. Extension is carried out by the latissimus dorsi and posterior fibers of the deltoid. Abduction and adduction, sometimes referred to as abduction and adduction, occur in the frontal plane. Abduction is carried out by the deltoid and the supraspinatus in the first 90 degrees. From 90 to 180 degrees, it is the trapezius and the serratus anterior. Adduction is carried out by the pectoralis major, latissimus dorsi, teres minor, adduction is carried out by the pectoralis major, latissimus dorsi, teres major, and the subscapularis. Horizontal abduction and horizontal adduction of the shoulder occur in the transverse plane. Medial and lateral rotation of the shoulder, also known as internal and external rotation respectively. Medial rotation is carried out by the anterior fibers of the deltoid, teres major, subscapularis, pectoralis major, and the latissimus dorsi. Lateral rotation or external rotation is carried out by the posterior fibers of the deltoid, infraspinatus, and teres minor. Circumduction of the shoulder is a combination of flexion, extension, and AB and adduction. The acromiooclavicular joint, or AC joint, is the joint at the top of the shoulder. It is the junction between the acromion, or part of the scapula that forms the highest point of the shoulder, and the clavicle. It is a plain synovial joint. The acromiooclavicular joint allows for the ability to raise the arm above the head. This joint functions as a pivotal point, although technically it is a gliding synovial joint, acting like a strut to help with movement of the scapula, resulting in a greater degree of arm rotation. The sternoclavicular joint is the joint between the sternum and the clavicle. It is structurally classified as a synovial double plane joint and functionally classed as a diarthritic joint. It is composed of two portions separated by an articular disc of fibrocartilage. The bone areas entering its formation are the sternal end of the clavicle, the upper and lateral parts of the manubrium sterni, and the cartilage of the first rib, visible on the outside of the bone areas entering into its formation are the sternal end of the clavicle, the upper and lateral part of the manubrium sterni, or the clavicular sternal notch of the manubrium, and the cartilage of the first rib, which is visible as the suprasternal notch. The articular surface of the clavicle is much larger than that of the sternum. Trauma may result in sternoclavicular dislocation. Posterior dislocation puts the neck structures at risk. Spontaneous subluxation also occurs sometimes. The scapulothoracic joint is a physiological joint in which movement occurs between the musculoskeletal structures. The scapulothoracic joint is a physiological joint in which movement occurs between the musculoskeletal structures, between the scapula and the associated muscles and the thoracic wall, rather than an anatomical joint in which the movement occurs directly between articulating skeletal elements. The scapulothoracic joint is where the scapular movements of elevation, depression, protraction, retraction, and rotation can occur. When elevating your shoulder overhead, roughly 1/3 of your shoulder motion occurs at your scapulothoracic joint and 2/3 at the glenohumeral joint. However, it is the timing and coordination of your shoulder muscles and how they control your scapulohumeral rhythm that is the most important factor. The movement of the scapula across the rib cage in relation to the humerus is known as the scapulohumeral rhythm, and this helps to achieve a further range of motion. This range can be compromised by anything that changes the position of the scapula. This could be an imbalance in parts of the large trapezius muscle that hold the scapula in place. Such an imbalance could cause a forward head Such an imbalance can affect the range of motion available at the shoulder. The shoulder scapular joint. Your shoulder scapular joint has a normal functional movement pattern known as the scapulohumeral rhythm. This provides you with pain-free and powerful shoulder function. When elevating your shoulder overhead, roughly 1/3 of your shoulder motion occurs at the scapulothoracic joint and 2/3 at the glenohumeral joint. However, it is the timing and coordination. Scapular movements relative to humeral Scapular movement relative to humeral abduction. From 0 to 30 degrees of abduction, there is roughly no scapular movement that truly occurs. From 30 to 90 degrees of abduction, the scapula upwardly rotates 1 degree for every 2 degrees of humeral abduction. From 30 to 90 degrees of abduction, the scapula upwardly rotates 1 degree for every 2 degrees of humeral abduction. This is known as the 1 to 2 ratio. Anything greater than 90 degrees of abduction, the scapula upwardly rotates 1 degree for every 1 degree of humeral abduction. This results in a 1-to-1 ratio. What are the symptoms of abnormal scapulohumeral rhythm? Poor shoulder blade stability results in abnormal tipping and rotation of your scapula, which causes your acromion bone to pinch down on the subacromial structures. This may lead to impingement or swelling or tears. Typically, signs of abnormal scapulohumeral rhythm include shoulder pain, instability, and clicking. Researchers have identified abnormal scapulohumeral rhythm as a major cause of rotator cuff impingement. The shoulder girdle consists of two bones, the scapula and the clavicle or collarbone, and the muscles that attach and move those bones. They include the rhomboids, trapezius, subclavius, pectoralis minor, and levator scapular muscles. The shoulder joint and shoulder girdle work together in carrying out upper extremity activities. Shoulder girdle muscles function to stabilize the scapula so the shoulder joint muscles will have a stable base from which to exert force moving the humerus. Shoulder girdle muscles stabilize the scapula so that the shoulder joint muscles will have a stable base from which to exert force in moving the humerus. They contract to maintain the scapula in a relatively static position during shoulder joint actions, and they also contract to move the shoulder girdle and to enhance movement of the upper extremity when the shoulder goes through extreme ranges of motion. In humans, the only true anatomical joints between the shoulder girdle and the axial skeleton are the sternoclavicular joints on each side. No anatomical joint exists between each scapula and the rib cage. Instead, the muscular connection or physiological joint between the two permits greater mobility of the shoulder girdle compared to that of the compact pelvic girdle. This is due to because the upper limb is usually not involved in weight bearing, its stability has been sacrificed for an exchange of greater mobility. The scapulohumeral muscles are a group of 7 muscles that connect the humerus to the scapula. They are among the muscles that act on and stabilize the glenohumeral joint in the human body. They include the coracobrachialis muscle, deltoid muscle, rotator cuff muscles, which include the infraspinatus, subscapularis, supraspinatus, and teres minor, and also the teres major muscle, which is not a rotator cuff muscle. Other muscles that attach to the humerus and affect its rotation and stability include the latissimus dorsi, pectoralis major, biceps brachii, and triceps brachii. In anatomy, the rotator cuff is a group of muscles and their tendons that act to stabilize the shoulder. The 4 muscles of the rotator cuff are the supraspinatus muscle, infraspinatus muscle, teres minor muscle, and the subscapularis. The rotator cuff muscles are important in shoulder movements and maintaining glenohumeral or shoulder joint stability. These muscles arise from the scapula and connect on the head of the humerus, forming a cuff around the shoulder joint. They hold the head of the humerus and a small and shallow glenoid fossa of the scapula. The glenohumeral joint has been compared to a golf ball sitting on a golf tee, with the golf ball being the head of the humerus and the golf tee being the glenoid fossa. During abduction of the arm, moving it outward and away from the trunk, the rotator cuff compresses the glenohumeral joint. This term is known as concavity compression in order to allow the large deltoid muscle to further elevate the arm. In other words, without the rotator cuff, the humeral head would ride up partially out of the glenoid fossa, which lessens the effectiveness of the deltoid muscle. The anterior and posterior direction of the glenoid fossa are more susceptible to shear force perturbations as the glenoid fossa is not as deep relative to superior and inferior directions. The rotator cuff's contributions to the concavity compression and stability vary according to their stiffness and the direction of the force that is applied upon the joint. In addition to stabilizing the glenohumeral joint and controlling humeral head translations, the rotator cuff muscles also perform multiple functions, including abduction, internal rotation, and external rotation of the shoulder. The infraspinatus and subscapularis have significant roles in scapular plane shoulder abduction that generate forces that are 2 to 3 times greater than the force produced by the supraspinatus muscle. However, the supraspinatus muscle is more effective for general shoulder abduction because of its movement arm. The anterior portion of the supraspinatus tendon is submitted to significant greater load and stress and performs its malfunctional role. Muscles of the shoulder include both superficial and deep muscles. The superficial muscles are used for mobility and include the deltoid, pectoralis major, trapezius, and latissimus dorsi. The deep muscles are typically used for stability and include the rotator cuff muscles. The subscapularis helps the shoulder with internal rotation, and the infraspinatus, supraspinatus, and teres minor perform the movement of external rotation.